I'm Dr. Asim Javed and I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning of image interpretation in coronary intravascular ultrasound.
Okay, so now on this, if you look at the longitudinal section, what you see is there is a green square here and there is a red square here. So this is to mark the area of interest. Otherwise, we have a long recording there. So if you want to increase the area, you can take it up till here. And then when you play, it will, you can see it's going to show you all the way from the green side to the red one. And you can stop if that's your area of interest. You don't want that long recording, so you can take this up till here, and then you can only get this much section for review. Right, this point is where this line is, and you see something black here. So what you need to do is bring your cursor here onto this blue arrow. You see this? Now you have this plus and minus button here. With this you can change the direction. So now let's go back to the cross section here. I'm pressing plus and you can see this moving, and so now you see there is nothing here, and you just see the intima and all that stuff, but you don't see any side branch. Now I'm going to bring this blue line onto this side branch and then see what appears here. So if I'm going to go on the other side, and now it's coming up, now it's on the speculated side branch, and look at the side branch appearing here in the longitudinal section. You see this black thing appearing here. So by moving this, we can see where the side branch is, and we can confirm that on the longitudinal section. Try to see what's the MLA over here. So we go to the dots, or you can even draw. So where we think the intimal layer is, we just put dots there, and then we press done. Okay, so now it's giving us an MLA of 4 millimeter square, right? Now keep looking at this. Now, is it the true plaque that we have lined up, or are there blood speckles in it and there is some artifact? So what we need to do is come to the longitudinal section, and there is a button over here, this one. So this is called dynamic review, where the arrow is. I'm going to press this, and then you see what happens to the cross section. So let's look at the cross section now, and I'm going to press this button now. Look at this. So what dynamic review means is the frame is going to move, it's going to go 3 frames back and 3 frames forward from this frame where we have done the measurement, and this will show if it's the true plaque that is moving, and you can see if you've outlined the true plaque or not. Okay, so I'm going to stop this dynamic review, and now another thing that I want to show you is, look at this lock sign here. If you press this lock sign, this will permanently lock the cross-sectional MLA that we've measured. And now if I move the longitudinal section, and then this will just kindly focus on the cross section there. I'm going to move from the longitudinal section to go forward and back. So this is there to compare with the reference segment your MLA of the lesion. So this is how you can compare what's the reference segment MLA and what's your MLA in the lumen. You can compare that. Or so now let's look at the longitudinal section, please. So I'm going to increase the area of focus and here, and then I'm going to take this bar down, and I want you to see the stent area now. So now I'm going to remove this, unlock this. Let's delete what we've drawn so far there. We will redraw this MLA. So this will be cross section of the stent now. Dots again. Let's see how well expanded the stent is. We know that the stent expansion is directly related with the ISR. So if the stent expansion is good, the chances of ISR will be low. So now this MLA is 8.2, or the cross section of the stent. Now I'm going to lock this here to see if the remaining stent is well expanded as well or not. So now look at the cross section piece. Just focus here, please. So this will remain locked. Now look at the stent here. So it's not as well expanded. Look at the stent here. So this is better expansion. This is even better than what we've drawn. So this way you can compare the stent expansion all over by just putting this lock sign on and drawing the cross section of the stent and then comparing it with the remaining stent. So this was just to show you how it looks. Okay. Virtual histology. This is for chroma flow and this is for ring down. So this is when you press the ring down button and you remove the ring down artifact. This is the virtual histology. And I'll show you what virtual histology means. So if we can go to the main screen, please. So if I play this and press the virtual histology button, so this is what you get. So what you are getting is green, yellow, white and red. And this is telling you where you have calcification, where you have, so we can just stop this. Okay, so in this case there is a stent here. So you can see these white are actually representing the stent borders, but otherwise if the stent was not there, this would be calcium. Then the red is the lipid core or the necrotic core, lipid rich plaque. The yellow is the soft one and the green is more fibrotic. So this is how you see virtual histology, and by pressing the same virtual histology button you can come back to the grayscale IVUS. For chroma flow, you need to have the chroma flow recording done while the chroma flow and ECG are connected to the patient, and for grayscale you have to repeat your recording, but virtual histology and grayscale get recorded at the same time. Looking at the other buttons here, so you've got bookmarks. You can press this button while recording if you have an area of interest, and in addition to that, if we go back to the main screen, during live recording, if you go to this home button and you press, right now it won't work, but during the live recording if you press this home button, then you get the option of changing the depth and the grayscale as well. During live imaging, if you press the home screen, the following settings can be seen, and this is where the settings can be changed. So to reduce the blood speckling and clarify intimal boundary, this gain can be reduced, which is normally or usually kept at around 50. Now depth can also be changed by changing the diameter, and normally it's kept at 8 millimeters, and this mainly concentrates on coronaries, but if you want to see anything beyond or deep, then you need to increase this depth. Now, intracoronary GTN must be given before IVUS, otherwise IVUS can lead to coronary spasm. And during IVUS pullback, you can put bookmarks at the points of interest, and at the same time you can do cine so that the 2 points are easy to correlate. So bookmark can be seen on the IVUS image screen, and your cine will tell you exactly at what point the IVUS catheter was when you recorded this bookmark image. Now in difficult bifurcation lesions, if you don't know the exact site from where the branch is coming off, so what you can do is, in these bifurcation lesions you can have 2 wires, so you can put wire in both branches and then start pulling back from one, and you will see the wire exactly coming out at the point of origin in the second branch. Then the O-ring is kept open while taking the IVUS in, but closed during pullback. O-ring should not be tightly closed, just enough to prevent back bleed. So that's why click system is better than the circle, where on the Y connector you have the rotatory valve. Instead of that, the click system is much better. Now for ostial lesions, this is where it becomes a little tricky. So disengagement of catheter is required to adequately image the ostium. If the catheter is engaged into the ostium, then you can't really evaluate the ostium. And non-coaxial imaging can result in overestimation of the lumen area. That's what is being shown here, that the catheter is non-coaxial to the actual left main stem, and therefore there is an overestimation of the lumen area. Now the guide catheter needs to be kept coaxial, You can even use a buddy wire if required to keep the guide catheter stable and move the IVUS catheter in and out of the ostium to assess it better. This is what I do. I record, if it's the ostium that I want to evaluate, then I record the image even while going in and then coming out. At the ostium, I do this in and out and record both just to evaluate the ostium properly. Now, for severe lesions, if it's difficult to pass the IVUS catheter through the lesion, it's by itself an evidence that the lesion is severe enough to not allow the IVUS catheter to pass through. So one should never force the probe through the disease. This can lead to breakage of the probe. This can lead to dissection in the coronary. So avoid using force. If it's not going through, just predilate if necessary. So what's the downside? That you will not be able to assess the MLA within that critical disease spot. But then there are issues that IVUS will help with. It can tell you the morphology, the plaque burden, all of other things you can figure out at the point where you predilated. Now, if IVUS is passed into a very severe lesion, without this predilatation, the flow may be compromised, leading to inadequate imaging with possible artifacts and even risk of complications.